Welcome, everyone, and thank you for joining us this evening. My name is Doreen Hindman, and I am the program manager here at Sashbear. The Sashbear Foundation is a Canadian charity recognized nationally and internationally as a leading voice for families impacted by emotion dysregulation, suicidality, and related mental health challenges. You may know us for Family Connections, which we provide across Canada, for these expert education series presentations, for our annual Sashbear Awareness Walk every spring held in cities across Canada, or for our many other activities raising awareness and providing skills and hope for families. You can go to our website at sashbear.org and follow us on social media to learn more about what we do. Now, as I mentioned, Sashbear is a registered charity, and that means that we gratefully accept your donations to help support our work. We ask that if you are able to support us, to please make a donation, however small, because every dollar makes a difference to what we are able to do. We also welcome monthly donors, and as we approach the spring season, we are also approaching our walk season, and you can find out more information about our annual walk at the link that is on the screen and that Barb and Trish will put into the chat. We will have our first walk happening in Ottawa this year on May the 2nd to kick off Borderline Personality Disorder Awareness Month in May. And then that will be followed by walk events in Toronto, in Burnaby, and in St. John's, Newfoundland over the next few weeks throughout May and into June. So our presenter is Dr. Amanda Uliaszek, and she is joining us for the first time this evening. I'm very happy to have her with us. She is an associate professor in the Department of Psychology at the University of Toronto, and her research explores personality pathology and emotion dysregulation with a specific focus on borderline personality disorder. This extends to research on mechanisms and outcomes of dialectical behavior therapy, the experience of emptiness, and stigma in BPD and those with disabilities. So I want to welcome you, Dr. Uliaszek. Thank you so much for being with us tonight.
Thank you so much. And I just wanted to thank Lynn and Doreen and the Sashbear team and community for welcoming me today. I'm really excited actually to talk to you again in the future as we're exploring some really great work within Sashbear and research that I'm doing as well. So what I'll do now is I'll share my screen and we can get going. So what I'm talking about today is borderline personality disorder and stigma. And so you might be thinking, okay, stigma, like we've heard of this. Are we going to talk about stigma more? What's new about this? Well, there's actually a lot of important and innovative and necessary things that we can touch on today. So I'm hoping this connects in with you, whether it be personally or with a loved one or a coworker or a client. I assume if you're here, you have some interest in BPD or maybe in emotion dysregulation. But sometimes when I'm doing a talk, since I'm a researcher, I'm also a clinical psychologist registered, but when I'm doing these research talks, I kind of talk about BPD as this like thing that we're trying to measure or understand or get rid of. But really, that's not my goal today. My goal today is for us to connect in with the person. You know, having a diagnosis of BPD is just one part of a person. It does not paint everybody in the same light just because you may have that diagnosis or I may have that diagnosis. We are all many, many things. So I really encourage you as we're kind of taking this journey about stigma and how does stigma impact those around us and maybe even ourselves. I want you to know, think about someone who struggles with mental health difficulties that you know. Maybe it's you, maybe it's a family member, but think about that is we can't paint them with the same brush. Think about 3 things that they're wonderful at. Think at 3 things you love about them. Think about 3 ways they have made you laugh. It is not having a diagnosis of BPD, having a mental health difficulty that one struggles with is not the entirety of someone's identity. And I think if we start to understand that there's complexities and nuances and gray areas, we can start seeing people more clearly for who they are, not being blinded by that diagnostic label or even the history that you have with someone. That's really kind of the feel of this talk that I want to impart, is that we're not talking about BPD as a thing. We're talking about it as a part of someone's identity, something that comes with maybe pros and cons. So keep that in mind as we're going through. So this is what I said, it's just one part of the person, right? So how am I going to do this? Like, how does this make sense? And how is this a research talk for starting out like that? Well, I'm going to first talk about, well, what is stigma? Like, what does it actually mean? We're going to talk about how BPD, how stigma is related to BPD in particular as a very, very stigmatized mental health difficulty. We're going to talk about how family members connect in with stigma, not only how family members can help fight against stigma and advocate for their loved ones, but also the stigma that you, if you're a family member of someone with BPD, you might receive on your end as well. And then finally, I'm very excited to share with you a self-stigma intervention called BPD Boost that we've created in my lab. It's been co-designed very closely with people with lived experience of BPD. And so I'm going to tell you a little bit about that. And if you're interested, if you want to be involved, if you would like to participate in that kind of group, I'll give you that information for how to do it. Okay. So again, this is not a talk about making people feel guilty about stigma. It's not about excuses. It's really about how are we all able to work together to remove those systemic barriers to people with BPD? How do we instill hope for loved ones and family members? That's really the takeaway message that I hope you have at the end of this. So think about we're going to talk a little bit about diagnosis, okay? So think about the time that you learned about yours or a loved one's diagnosis, if that has happened to you. Did you imagine kind of certain doors closing? Did you feel like maybe opportunities now were lost to you? Or did you see now certain doors were opening now that you had an answer to what was going on, that you felt hopeful or you felt that there were new opportunities in the future? So we need to really understand how stigma and how the diagnostic label of BPD either closes or opens doors for us. So what opens or closes doors? Well, we would hope that the specific actions, goals, and circumstances of an individual, so you as a person, what you specifically do is what determines the opportunities that you might have or the opportunities that you don't have. Unfortunately, many times opportunities are closed or withheld from us because someone assumes that we have a deficit, a certain quality, a certain potential based on a group to which we belong. Okay. So in other words, while I might want, my job prospects to be purely based on my intelligence, my dedication, my work ethic, the fact that I'm a woman or a mother, those things may cloud some people's ideas of what is an appropriate job for me before they know anything about me. So the same with someone having a diagnostic label of BPD, people may assume that they are unable to do certain things or assume that they should do certain things. And this is where stigma comes into play. So that is an example of where stigma takes effect. So in order for something to be stigmatized, there is a label placed. So you are put in a group. So whether that be someone with BPD, it could be someone who is young, a teenager. It could be someone who does not speak English as a first language. These are all kind of labels or groups someone may belong to. But now the second part involves a judgment or a belief. So one is assuming that all the people with that label are one thing, they are one way in a certain characteristic, and that thing is undesirable. So that's an example of stereotyping, right? So you judge that person to be undesirable or different, and then there is an associated action where you separate yourself or discriminate against them. You remove opportunities. So in general, a stigma is when negative attitudes or discriminatory behaviors against a person based on a specific characteristic or condition that they possess. And I'm sure that if you thought about it, you may have been stigmatized in your life based on who you are, or what you look like, or a group that you belong to. One example I could think of for myself personally, this happened a very, very long time ago when I had a new baby at home, so over 10 years ago. And I was privy to an email. I was trying to have a meeting with a psychiatrist that I was working with. And in the email said something about new mothers are always expecting to be catered to. I'm going to make her schedule really, really difficult because I'm just sick of dealing with mothers think that they deserve special treatment. So even though this person didn't know anything about me, even though I hadn't asked for any kind of special treatment or anything like that, because he had put me in this category, he was systematically making things more tough for me. He was blocking my access to be able to work in that kind of environment. So that's just a small example, but I'm sure you could think about a time where someone labeled you in one way, correctly or incorrectly, and then there was some kind of resultant negative consequence. Now, here's the other part. When have you become aware of your own stigmatizing beliefs? Now, this isn't meant to make people feel guilty or defensive or to shame anyone. All of us carry certain heuristics or stereotypes. Our brain can't simply process all of the information that we need. We make judgments against people all the time, or about people, I shouldn't say against. And sometimes we just don't know. We don't know the relevant information, even if we could sit down and process it. So we may have been enacting and participating in the stigma even when we didn't intend to. It's really hard to acknowledge that sometimes, but that's going to be important to become an advocate or an ally, is to notice when you are doing something that maybe is contributing. And that could be as simple as treating someone as fragile when they haven't asked to be treated in a more delicate way because you think they can't handle something. I realized I was doing something stigmatizing when and this is research related again, but I would search for literature, you'd search for articles and stuff, you're trying to learn, and I would ignore anything not published in English. I just automatically would ignore that. And what I was doing, not really realizing it, was I was systematically eliminating a whole groups of people to contribute to the knowledge base and move things forward. Where I easily I didn't need to be doing that. It was just something that I did to make my life easier without actually thinking it through. So really, again, think about times where this is coming up for you or when you notice. And you might say, oh my gosh, but I would never stigmatize anyone. Well, it doesn't have to be as blatant as what I've just said, right? It doesn't mean you're in the street holding up a picket sign saying, I don't want these people near me. Do you ever find yourself feeling scared or angry regarding a group of people? Do you try to avoid a certain group of people? If you see someone, do you want them to stay away? Do you consider any groups to be dangerous? Do you find yourself pitying a group? So that is also a form of stigma. Or do you blame a group for their circumstances? So if you have found yourself in that kind of a situation where you've looked at someone and said, well, that's their fault that these people are like that. Well, that might be a case where you may be holding some stigmatizing beliefs. So just pause and think about that for a second. Did you ever avoid someone, be segregated from someone? But now let's turn it a little bit. What about you? Have you ever blocked off your own kind of opportunities because of a label you associate with yourself? So has the stigma ever turned internally, like saying something like, people my age don't do this, or people like me have to do this, um, or, moms can't act like this, or people from my cultural background, we're not allowed to do stuff like this. Is there anything about it that's holding you back? And in particular, have you ever said to yourself, well, I have BPD, and so I'm never going to be able to do something like that? So when you take your label and you tie your label to your opportunity instead of your specific circumstances and goals and values to that opportunity, then we can sometimes find ourselves in a problematic self-fulfilling prophecy. So think about that. And let's talk a little bit. I very purposefully tried not to talk too much about stigma and BPD yet. Our advisory, which I'm going to keep talking about, this wonderful group of folks with BPD who have helped design this whole project, talk about how when you talk about stigma, the first thing that people want to talk about with BPD is they have a big slide up of all the terrible things people say about BPD. So I very, very carefully and consciously not wanted to start like that, because stigma is a problem all over the place. And so we're going to talk about what we know about stigma first, and now we can talk a little bit about how we have understood it to relate to BPD in particular. So we have stigma that comes from just society, the community that you live in. This could be hearing it from the media or from the news. So something like, people with BPD are dangerous. There's a lot of news stories about how to date someone with BPD, which again brings forth a lot of stigma, and just the general kind of public's understanding of where stigma might come from related to BPD. We have institutional stigma. So this is where there's actually policies in place that discriminate against people with BPD or affiliated kind of symptoms. So for example, there are mental health clinics that exclude people with BPD. So where there might even be screeners or questions. And if someone is BPD, they're thought of as too high risk and referred out. So it actually blocks their access to receive that type of care, not based on the presenting problem that they're coming with, but instead on that label. Could be things like, I do a lot of work with university students. There's a criminalization of suicidality. So if you are feeling suicidal, there have been policies in the past where you are handcuffed and taken out by the campus police because it's a criminal act to try to hurt yourself, or a mandatory leave for a student who expresses suicidal thoughts. Whereas, I'm gesturing, I'm not meaning to do that. And so these are the institutional policies that unintentionally, but do impact specifically those people with BPD. The last one is one, if you do have BPD or you're a caregiver or a family member of someone with BPD, you may have experienced provider stigma, which is some of the most common with medical professionals or even mental health care professionals having stigmatizing attitudes towards people with BPD. So here's that slide. All the things that have been noted as being related to BPD, stigmatizing language that is often used. And when people with BPD report, they say these are the kinds of words that are thrown at them, and it really causes significant disruption in their lives. So these are things like, interfering with access to treatment. Like I just noticed, there's increased rates of unemployment that can be traced at least in part to stigmatizing attitudes. There's social isolation and loneliness. There's misdiagnoses. All of these kind of things floating around, whether it be through healthcare professionals, people in the emergency room, what you see on TV or hear in a podcast, or even things coming from your school or your workplace that really serves to block your access to care in a high functioning lifestyle. Now, if you are a person who's being constantly told when you go to the emergency room because you hurt yourself or you're sick, when they see that you have BPD, they discount the symptoms that you're expressing, or when you go to your workplace and you're told to stop being so emotional at work or to get over it, or no one wants to work with you at work, or when you're watching TV and there's some dangerous person on there and they say this person has BPD in the show. If you're constantly inundated with this type of information, it's no wonder that, here we go. It's no wonder that you start hearing those doors slam shut. So if you heard the door slam shut, that's what it was. Here it is again. So as you're hearing this, you're starting to become aware of all the different problems, all the different lost opportunities, and those things can all come together and become self-stigma or internalized stigma, where as a person, you become aware of society's labels, you become aware of society's judgments, and you start to agree with them. You start to apply it to yourself. And then your self-worth takes a nosedive. You start to think, well, maybe those people are right. Maybe I am dangerous, or maybe I'm not good in relationships. These are the things that start, that people with BPD start to hang heavy in their hearts as they start to think about these things. And self-stigma is a major issue for people with BPD. There's been a decent amount of research on self-stigma in BPD. It's higher than most other mental health disorders. People with BPD have higher rates of self-stigmatizing thoughts and attitudes. And it's inversely related to quality of life and to self-esteem. So it really is one of those things that hangs around, and even as BPD symptoms are getting better or life-threatening behavior is improving, there is still this lack of self-worth or this lower quality of life because still identifying with the stigma that's associated with this label. So feeling like the doors are slamming shut still. The doors haven't even opened yet, even if someone is receiving treatment and they're doing well. So there is one thing I want to mention based on the research, is there's a bit of a dialectic regarding the label of BPD and stigma, okay? So, and this is an oversimplified approach to understanding what I'm talking about, because you might be thinking, well, I do know somebody with BPD and they are doing, some distressful kinds of behavior. So I should react to that and I should respond to that in a way that's helpful to them or that is conscious of that history. And that's true. That's what we differentiated by saying we want to base this on people's personal actions. You might be a person with BPD who thinks, well, when I heard that label, I felt tons better because it actually made me feel like, oh, there is a name for what I'm experiencing. There are treatments for what I'm experiencing. There are great organizations out there that help people like me. And I'm so, so glad I have this label. And that's true. What we've found in research and what research shows is that when the label of borderline personality disorder explains a kind of distressing or symptomatic behavior, it often actually reduces stigma. So it's not that the label of BPD for everyone it increases stigma across the board. So when it's associated with something that's distressing, either this is a great study just finished by my grad student, Maya Amistoy, who I'm going to talk a little bit about towards the end more, but about public stigma. So how do the general community feel about people with BPD? And also with self-stigma. So getting that label can often be really helpful. On the other side of the dialectic, when the label is attached to non-distressful behavior, so not symptomatic or that kind of behavior, just, if someone is just, walking along and not doing much, and then they're told, oh, that person has BPD, that may increase stigma a little bit. There may be more hesitancy, though this does interact with other aspects of identity. However, in the healthcare context, it's pretty consistent as BPD is stigmatized. So a label of BPD in the healthcare context, regardless of if it has to do with a mental health care professional or just a typical medical professional, there is a lot more stigma in the healthcare sector. I hope this makes sense if you were feeling a little bit like, well, the label can be helpful too. Absolutely, 100%. Okay, so that's kind of what's going on with BPD and stigma. So just to summarize, a lot of self-stigma, high levels, negatively impacting self-worth, but some benefits of having that diagnostic label some of the time. So how does this relate to family? So if you're here, you're a family member of someone with BPD perhaps, or someone with emotion dysregulation difficulties, you might be thinking, okay, well, like where do I see myself in this? Like, please don't make it just that I'm the one reinforcing the stigma, right? Well, no, absolutely not. So there's this great study that just was published. So I have the citation here, Van Schei. This is out of Australia. And I really want to talk about this study because it's one of the few studies that's really connected in with family members and understanding how family members' perspectives make a really, really big difference. And that's so relevant for Sashbear, right? Because families are at the heart of everything that's going on. So I really wanted to bring this in. The word cloud behind you, like if you can see a little bit of the word cloud, that's actually from this study. And these are words that people with BPD found most commonly associated with stigma. So that's in the article if you wanted to see the full word cloud. But let's talk about family. So I thought this was really interesting. So they brought in a big group of family members. They call them carers. So family members of people with BPD. And they actually really were interested, like, do you experience stigma? So are people shutting doors on your, in your face? Are you losing opportunities? Do you feel stereotyped because you're the carer of someone with BPD? And they actually reported a lot of stigma. So maybe you're nodding your head right now at home while you're watching this, or maybe not. Maybe it's not something you've shared with people or you've experienced, but they reported that the most stigma came from clinicians, from mental health care clinicians. So saying things like, you're crazy to put up with that they'll never get a job. Oh, they're just a typical BPD person. And so really that clinicians, the stigma we already talked about, that provider stigma really comes across feeling very derogatory towards carers. They also had stigma from, friends. Oh, they'll grow out of it. Like, why are you so worried about your loved one? Like, you're overreacting. And then from the person with BPD, the loved one, saying things like, it's your job to take care of me, or you should stop nagging. So they felt very discounted often. In summary, do think it's in the next, no. So in summary, what they felt they were often trivialized and that they were often blamed. And so that was the kind of the stigmatizing experience for family members. Their emotions were not validated and that they were blamed for problems. Just to jump back to the stigma experienced by the people with BPD in this study, they reported it was actually most commonly by family members and friends. And second most was first responders and clinicians, so healthcare professionals. And so again, these are quotes from the article. Again, family members are receiving the end of the stigma, the short end of the stick there, but they're also maybe perpetuating some of the stigma, but likely out of frustration or for lots of reasons. So it's important if you are a family member and you're watching this to think about kind of your role in here. They had like this interesting kind of diagram. I'm not sure if you can see it well, but again, this is out of their article. So you have the response of others, that's the leftmost column. You have all the different things that were happening to either caregivers or people with BPD. So the dash line are the carers, so showing that, you know, they were blamed, needs were being ignored. And then these are the responses. So feeling very frustrated and feeling inadequate. The inadequate was for the people with BPD, whereas the frustration was for the family members. So it really related to a lot of negative emotions, having to, confront these stigmas. Okay, so what do we do now? So we've talked about there's a lot of stigma going on, there's problems, it's transactional. This article, which is where I'm going to start, offered some places for help. So this was the other side of it. So these are wishes, that's the third one, and outcomes. And so really this was just a great diagram. I absolutely loved it to show all the different ways that, and this is co-designed with people with BPD and their carers. These are the things I want. I want acknowledgement of my distress. So it's not that you need to fix my distress, you need to remove it, you need to solve my problems. All I want is I want you to acknowledge that this is a really difficult situation that you're in, or you're having a lot of feelings right now and it is really tough. We all know that is validation, right? Carers wanted support from others. So how can I help you? What can I do for you? Is there anything, do you just need to talk? You know, that's what support is. Like, I'm here if you need me. Send me a text, give me a call. For people with BPD, they really wanted to be seen as a person and to feel understood. So not just a label, but as a person. And the outcome was lots of positive things like acceptance and connection. So it's a really good place to start. Can I validate? Can I remember that exercise I had you do in the very beginning? I mentioned, think about, the person with BPD, how they make you laugh, what you love about them. They're a whole person. They're not one act of behavior, or they're not one label. They also provided some helpful wording. So you can see this was a word cloud that they made regarding helpful wording, like validating, how to be supportive, care, there is hope. That must be difficult. These kind of things. These aren't, cliches. If you look someone in the eye and you tell them, wow, this is difficult. I feel that from you right now. That's powerful if you can get down in there with them. And so using helpful wording is the first step with stigma, with us fighting against stigma. Can you be an advocate? Can you move it one step further? So can you provide fact-based education and correct misinformation when people are mentioning things about BPD? So, you can, but don't lecture. So that's why it says question. So when someone says something to you, oh, well, aren't people with BPD, they can never get better. Oh, well, what makes you say that? Where did that kind of where did you hear that information? I'm curious about that because that's not been my experience. Or I heard that you can't, I was dating this girl and she had BPD and I had to break up with her. Oh, that seems like quite a jump. Can you, tell me more about that? Because I wouldn't have made that same decision. So again, I'm asking questions instead of lecturing someone on, why I think it's bad. Now, why don't we lecture someone right off the jump? Because people don't like it. They get defensive, they clam up, they're not going to learn anything. But when we question someone, it allows them to kind of think through their own decision-making process, and that can be really helpful. We want to educate people, like I said, fact-based education. If you want, you can speak openly about your personal experience if you feel comfortable. And you want to validate before you try to get someone to change. So you want to be conscious of your language and tone, talk to them about, oh, that must have been confusing when you heard about that label. I can see why you might have been confused and you wanted to respond. And maybe if could I offer you some information on something you could do next time? And so if you can do these things, if we can change our wording, if we can be aware of how to ask for help, and if we can question, educate, and validate, that's really going to help us as we confront stigma in our day-to-day lives. The last thing I want to talk to you about is a new self-stigma intervention that we've developed at U of T called BPD Boost. So overcoming the obstacles of stigmatizing thoughts. So even as treatments are helping, even if someone is doing wonderful in treatment, there can be kind of a fear of changing who you are or being only temporary, or it's too good to be true, or I don't deserve this. And it really can contribute to a lot of this self-stigma kind of talk, even when someone is doing quote unquote well, that it can still hold them back. So we've been working since the fall of 2021 actually to develop this treatment with the advisory committee of people with BPD. And we started with Boost, not BPD Boost, which is a anti-stigma intervention for psychosis. So that's where the Boost comes from. Be outspoken and overcome stigmatizing thoughts is a co-design intervention for psychosis. And so when we connected in, we started to review that original content, and then we really changed so much of it to make it relevant to people with BPD. And I talked about my advisory. So what is it? So it's 8 group sessions done remotely right now. They're 90 minutes each. And we have both a clinician lead as well as a peer co-lead. So someone with BPD co-leading the group. And the idea is to provide ways to respond assertively to stigma, but then use cognitive strategies to to confront self-stigmatizing beliefs, increase self-compassion, and then how to understand action urges. So respond and not react. Everything is taken from evidence-based kind of practices like cognitive behavior therapy and dialectical behavior therapy, but made to be relevant to stigma and BPD or specifically. So our overview of our sessions, what I'm going to do as I end this talk in the next 5 minutes or so is I'm going to show you very briefly a little bit of our content from each of these weeks so you can get a little bit of an idea of the types of things we'll be doing. I will mention group therapy, I think, or group interventions. A lot of what we know. Oh, my dog woke up now. She's going to be a problem. What we know is that one of the wonderful things about them is that you connect with people who identify with an important part of you, that they see you and you see them. And you become, there is group cohesion, you connect with your group leaders, and you have this space to be yourself. So that is our primary goal. Beyond that, I'm going to assume that you understand that's part and parcel with each little bit of BPD Boost, but I'm going to talk to you a little bit about the content that we would share in each. And every session has activities, discussions, ways to connect, and then things to do at home in between groups. So it's not just a lecture. So the first thing we do is kind of an introduction to group. We talk about validation. And we talk about what is stigma, very similar to what I did. What I have is our handouts that we would be using. So I just have copies of the handouts here in the slides. So it's really just a visual cue where I'm not going to go over the content. What we'll do then for session 2 is we turn to internalizing stigmas. That's our main focus. And so you can see an activity here I have on the screen. choosing a label that makes you feel positive, choosing one that makes you feel negative, and we talk a lot about action urges. When you hear that label, when you notice that label, what do you want to do? What is the urge that comes out? How do we start to notice through mindfulness what our urges are and then respond accordingly? We also really emphasize a talk about shame, because shame is often associated with internalized stigma or self-stigma. So we really want to understand that shame is a part of all of us. And there's an adaptive side to shame. And we're never saying that any kind of emotion is not allowed, but there are going to be times where shame does not work for us. And how do we address it? There you go. And then we have where we're talking about other emotions too. You can see the emotion wheel. Session 3, we're talking about BPD and stigma. So very similar to the talk we're doing right now. So people can share their experiences, but we also try to really talk about, well, what's positive about having BPD? Like, what do you get from your label? Having such a rich emotional life, what's good about that? And we talk about celebrities with BPD, which we have quite a few that we found. Session 4 is really cognitive therapy focus. So we're trying to change the beliefs. We're not trying to change the label of BPD. We're not trying to get rid of someone's BPD. We're trying to alter, when we think of this label, we catch our automatic thoughts that come with it. We check the facts, and then we try to change the response. In session 5, we switched to communication skills, and we really, really focus on assertiveness. So we talk about being aggressive, we talk about being passive, we talk about being passive aggressive, and then we talk about how to practice assertive communication. However, I will say that we do talk about, there are times where assertiveness doesn't work and it's not the most appropriate. And we talk about cultural factors that relate, how if we're in certain kinds of tumultuous relationships, how assertive might be viewed, and thinking about safety and such. Session 6 is more about provider stigma. So this is external stigma again, but how do we respond to and overcome that when we're disclosing diagnoses to healthcare providers? And session 7 looks really like almost like exposure behaviorism. So we're going to talk about, we have our emotion, we have an urge. How do we do the opposite of that? So if we're feeling anxious, do we decide the anxiety is ineffective, or the shame is ineffective, or the anger is ineffective? And how do we do the opposite of that? And then session 8 is our review, a celebration, and we do some goal setting. So how do we kind of take this further and understand more about how self-stigma might come up in the future and how we can address that going forward. So that's a summary of what our self-stigma intervention will look like. The research as well as the intervention has been co-designed by our advisory committee of people with lived experience of BPD. And we're assessing many different metrics to see, do these things change as a result of our 8 weeks of self-stigma treatment? So here are some of the things that we're looking at. So I will say, if you are interested at all in being a part of anything we're doing, so at the STEPP Lab is my lab at the University of Toronto. We are currently researching all sorts of ways to reduce stigma in BPD. If you are interested in the intervention that I just talked about, BPD Boost, if you're interested in advisory committee work, if you're interested, I'm about to do some research projects with Sashbear and Family Connections. So if this is something that you're like, wow, I'd really like to get involved, because science and scientific dissemination is one way that we kind of move the needle on some of these things. We gather evidence, we understand more, we can help more people. Please feel free to connect with me. So I have That is my lab email address. There, I have my personal email on the last page. And if you're interested in participating in BPD Boost, we do have assessment time points, like questionnaires and brief interviews, but we do compensate for your time. So we pay for people to participate in the research. So if you are interested in the research, like I would love to hear from you, or if you have questions, you feel free to email me. Before I stop, or maybe if there's questions, I really have to acknowledge some people. So I really need to acknowledge our advisory committee. So they preferred to have their initials here. They have been, I can't describe how grateful I am to them, for they were with us every single step of the way designing BPD Boost. They've been amazing, willing to share their stories and connect in. So a big, huge thank you to them. Selena, who's a research assistant, and Amanda, who's a former lab manager. Selena made these wonderful handouts, or had a big hand in it. Same with Amanda organizing the study. And then the biggest thank you to my grad student. I even have a picture of her, Maya Amistoy, who is absolutely like the heart and soul of BPD Boost, has been excellent through all of this and is doing wonderful work on BPD and stigma, and is in her PhD, finishing her PhD 1 right now. So a huge thank you to Maya. Oh, and I bolded her name. There it is. So again, thank you everybody for your attention today. I know it was a lot of information to cover, but I really hope it again brings to focus for us to all be a little bit more mindful when we're saying things or what we're receiving, and how we might respond when we're hearing stigma about BPD, or really anything. And if you would like to get in contact with me about research opportunities or advisory, we pay for the advisor if you're on the advisory committee too. I mean, that's paid work. If you're interested in being involved, you can look, there's my email, my lab website, which is maybe a couple of months outdated, but I have goals to update it. And again, it's the STEPP Lab at the University of Toronto, and there's my name and information. So thank you all very much for your time, and I'm happy to answer a couple questions if there are some.
Wonderful. Thank you so much. I do have some really great questions here. A couple of people have asked, first of all, about the name, just the name itself, borderline personality disorder. Seems to contain a lot of stigma, right? It's like, oh, you have a defective personality. You're on the borderline of something. What is your thought around that? And is there research? Can the research around stigma help us change the name of the disorder?
Yeah, that's a great question. There is actually some research studies on that where they've tried, I think, Linehan's disorder and maybe emotion regulation disorder or something like that. So they've done studies with, community where they presented kind of the same description of a person, but with different labels to see if it resulted in different levels of stigma. Those studies, there are not a lot of them, but they actually didn't find that it helped. So even different alternative names that didn't say personality disorder, they had similar levels. They reported similar levels of stigma. Besides that, the name borderline is extremely outdated, and it's a historic name. It relates back to object relation psychodynamic stuff from 75 years ago. So it's quite outdated. It doesn't really relate to how we think about BPD now. I am also an advocate for talking about what's really wrong and not necessarily always falling back on a label, at least with healthcare professionals. So we do know, and I present this slide sometimes of like, there's 256 combinations to get a diagnosis of BPD because it's 5 out of 9 symptoms, right? So BPD doesn't always give us a lot of information. when we use that as a label. So I don't know what a better name. I think that would be an interesting question to ask people who identify with that label, is what they would prefer it to be called, rather than borderline personality disorder.
Mhm. Great, thank you. When you talk about, maybe being a little bit more descriptive, there's also a couple of questions around how do we talk about BPD and describe the symptoms or explain what it is without, it's like almost automatically that becomes stigmatizing because there's so much negative in the way that we describe it. Are there
Yeah.
positive ways to describe it or better definitions to use?
Yeah, that's a great question. I think it's one of the drawbacks to psychiatry, or, these names come from psychiatry, right? Is that they're deficit models, meaning we describe what's wrong. And so inadvertently, whether you're describing borderline personality disorder or you're describing someone with panic disorder, you're talking about ways that they're struggling, ways that they might be different than someone else. So it can almost always come across as negative. I think, Marsha Linehan had some good ways of describing the experience of being a person with BPD. So the idea that to almost describe someone as being, she had a quote about being kind of covered with third-degree burns. So every little tiny slight or touch is experienced very strongly. That might be some way that identifies with certain people. But if we can describe it as, well, I have this rich kind of emotional life. I have big emotions. And sometimes those big emotions, it gets in my way of being able to think clearly. And I might be doing things that are maybe not the best idea for me at the time. Again, I don't want to over generalize, because everyone with BPD has a different kind of experience with BPD. The more specific you can get about how you experience the disorder, and then offering suggestions on things that are helpful, I think that can be a positive way to share with someone about the diagnosis or about your struggles. So whether it's, sometimes I get very anxious when I'm in a close relationship with someone, makes me really, really nervous. But a good way that I deal with that is I just like to do a check-in once a day just to say, hey, and how you doing? And that really helps me. And that's how I cope. And, you can give someone, you can present kind of the issue that you want to let them know about, but then maybe also a way to connect in and head off that issue too.
Okay, thank you. There were also questions about the relationship around how much stigma there is within the healthcare community. So I have a couple questions about that.
Yeah.
First of all, is it reasonable? Is it possible? If you have BPD or a mental health diagnosis, can you ask your healthcare provider not to disclose that when they're doing referrals for other medical issues? Because there is so much stigma. And if they see that label BPD attached to, oh, you've got a heart issue.
Yeah.
And then you're faced with that stigma again.
Yeah, I mean, your health records are your health records, right? So, well, I guess it depends where you live, but for the most part, you have a lot of control over them and access to them. At the same time, if your healthcare professional feels it's necessary, there's some reason, there's some risk factor that's involved in your diagnosis, and they want to put that as part of your file, you're probably unlikely to get them to agree to that. But if it's not something that's important, then I think it's absolutely within your rights, and could be a good idea in some aspects to say, you know what, I don't think it's relevant to my heart condition, so I'd appreciate if that wasn't part of the referral information. But if you're somewhere, depending on where you live and what you do, when it's a big hospital and you're also receiving mental health care there, or those records are going to be viewable often. So just to keep that in mind.
Good point. Okay. And Is there, I was surprised, you said there was, one of the highest communities for stigma was the clinicians themselves doing this. So are there historic reasons or contemporary reasons as to why there would be so much stigma within those communities, either the clinical mental health clinical communities or medical healthcare communities?
Yeah, it's kind of this idea that if if a group is thought to be difficult to treat, then people that are in positions of care, of healthcare, already are feeling hesitant or reluctant, and it poisons the pool. So they're already there's a chance that these people, so people with a BPD label, for example, are going to get less optimal healthcare. They're going to have people that are less willing to provide healthcare, and then it just feeds into itself. So you're not getting the best healthcare. You're struggling, and you're going to multiple clinicians. You're having a hard time connecting in. It's I don't know, chicken or the egg, what started first, but there is this historic belief, and that's one of those stigmatizing things that come up often for BPD is that people with BPD are treatment resistant. They have a hard time in treatment. And that's really until dialectical behavior therapy came around, that was it was well known, I think, or well shared in the mental health care community before the 90s, that you couldn't really treat people with BPD. But now that's changed, and we know that's not true. Even if someone doesn't receive treatment for BPD symptoms wax and wane over time. You just because you're experiencing it one day doesn't mean you will the next. So I think it's just an outdated phenomenon when people were afraid to engage with people with BPD, and it's just kind of left over. But there still is that stigma. That's one of the most consistent findings we have in research is not only mental health care clinicians, but like emergency room doctors and nurses as well. You also have to think for them, like maybe they're seeing a person with BPD on that person's worst day, so they're seeing them on their worst day. And so that becomes kind of the assumption that everybody's like that every day.
I guess there's, like anything else, there's work to be done in that community as
Yeah.
well.
Yeah.
And I suppose the knowledge around personality disorders tends to be it tends to be a specialty, right? So
Yeah.
generalists may not be exposed to all of the most current information and research, right?
Yeah. And I think it's tough too, because at least most mental health care is not done by psychologists or psychiatrists. It's done by counselors and social workers. And diagnoses are not part of the training because they're controlled acts, right? You have only doctorate level people can diagnose. And so it's actually, we've been talking about, and there's an article recently submitted by a colleague that I'm a part of how to right from psychology undergrad curriculum, BPD is talked about in a negative way. In textbooks, it's talked about in a stigmatizing way. And so we even have to go before the mental health care professionals are trained or the healthcare professional go to grad school or medical school or nursing school, even what they're learning at age 18 in their intro to psych textbook is stigmatizing about BPD. And so we have a paper recently submitted about how to change the curriculum actually in psychology to talk about BPD in a less stigmatized way, because I think it starts very early of how people are understanding the disorder.
Yeah. That's exciting. I hope that has some effect as we move forward.
Yeah, just been submitted, so hopefully.
Great, great. There was a question about acceptance. I noticed on one of your slides, with many different words, validation
Yeah.
was one piece and acceptance was another. Could you maybe say a little bit more about specifically the DBT skill of radical acceptance and how radical acceptance might be able to impact stigma? I can think of some ways myself that it might come into play, but I'm really interested what you might have to say about that.
Absolutely. And I think acceptance is tough because if you're not familiar with kind of the DBT or mindfulness idea of acceptance, how we use the word acceptance just in day to day, it sounds kind of like resignation or agreement that, well, this is my disorder and it's stigmatized, and I guess I have to accept that. And that's not what we mean, right? When we talk about radical acceptance or acceptance in the mindfulness way. Here we're talking about seeing the world in your current situation for what it is. So seeing the facts and acknowledging that these are the facts of my situation right now. And I'm going to base my next move, I'm going to base my goals, and I'm going to base hopefully kind of my emotional response on these facts. So I'm not basing it on what I wish it was. I'm not basing it what I think is the fair thing. I'm not basing it on what my sister or my mother's situation is. I'm basing it on what my situation is in reality. And so that's what radical acceptance really means. And it can sometimes come with sadness. Sometimes we're sad about the doors that have closed, but sometimes they have closed. And so to fight against the door and bang our fists on it and bang our head on the closed door, that's the opposite of radical acceptance, right? It's fighting against reality. So in the case of stigma, it'd be nice to say that I can think of a few ways, like you said, that this relates to stigma. It'd be nice to say, oh, well, now that people are educated and there's all these anti-stigma campaigns, like stigma doesn't exist anymore. So isn't that great? We can stop talking about it. The fact is it's not. If you're watching this, you're likely have been affected, and you will be affected again in the future. Someone is going to say something to you, or someone is going to do something to you that results from a stereotype about what is BPD, or what does it mean to have a mental disorder, or to have experienced a suicide attempt, or to self-harm. If we pretend that doesn't exist, and just go along in our lives, we're not able to fight the good fight. You have to actually acknowledge it and have your eyes wide open to be able to fight against it. So I don't think it would make sense for us to pretend that it doesn't exist. But when we say we radically accept that this is happening, we might feel a little sad that this is our world that we're in. But now we can see it for what it is, and we can decide on our tools to make a change. So that's kind of part of where radical acceptance could come in for that. If it's something with dealing with your own diagnosis, or maybe a family member's diagnosis, that can be really, really, you may have experienced this if you can think back to when you heard about a diagnosis. Maybe you originally were angry, or maybe you were in denial, or you thought this is not fair. This isn't right. I can't deal with this. I can't handle this. Those are all showing non-acceptance, that I'm unable to kind of process and look at the reality. But often when we say, okay, I need to accept that this is the situation I'm in, this is the disorder, and it's right, it feels right, actually. You might be a little bit sad. And at the same time, you can start to make those planned actions for moving forward, for getting help. So radical acceptance is this way of being able to acknowledge what's in front of us, but then make the changes to go forward.
I want to turn now maybe to the family situation, just maybe as our last question for you to address is, how can we as family members maybe recognize a little bit more of the stigma that we ourselves are holding within us, and try and reduce that as we're interacting with our loved ones who have BPD?
Yeah, and I think, I was really excited to just acknowledge today that family members are probably, you may be taking the brunt of some of the stigma, right? So maybe if you're hearing it or you're seeing it, that's really hard to stomach for someone you love. And so maybe some of that does come out in terms of frustration. I think, ask yourself, if you're shutting doors for your loved one with BPD in your mind. So this is often looks like they're not going to be able to take care of themselves, get a job. They're not going to survive without me. have a stable relationship. If you're shutting those doors, what we often say with radical acceptance is you can't radically accept the future. Those things haven't happened yet. The never or always, you can't know. So if you find yourself saying things like that, or even thinking that, to be able to take a step back and focus on the situation that you're in right now. So saying something like, you're never going to be able to take care of yourself. What's going on right now that needs to be addressed? Saying something is never going to happen is probably imparting some of that stigma of, BPD being associated with lower, life functioning. And if you need help, take a breath, take a step back, come in and validate, reflect back what that person is thinking, feeling, doing. This looks really hard. Even if you don't have to agree with it, right? So even if your loved one is doing something you would never do, or responding in a way you would never respond, you could very much acknowledge that they look like they're in pain. I can't believe you must be in so much pain right now if that's what's going on for you. This must be really, really difficult. It hurts me to see you hurting so bad. Instead of immediately trying to change what they're doing or tell them what they're doing wrong. I think sometimes that is a way to start. And then the opposite of it is overly fragilizing your loved ones. So if you avoid telling them things, if you think, well, they can't handle to hear this, that's something to start working on as well, because then you're never giving them the opportunity to learn those skills, to start to flourish a little bit in terms of, these other things that are happening in life. And it's day to day, try to take it as one situation at a time as much as you can. Super hard for anybody. Doesn't mean not just people who have a loved one with BPD, but it's really hard to do that anyway, like within our families, to not say, well, you never, but trying the best you can, I think, is another important way to start.
Great. Thank you so very much. I think we will leave it there. I know your time is precious, and I thank you so very much for having been with us this evening. I'm sorry to our audience that we were not able to answer all of your questions, but if you have a question about the family piece and you're at the beginning of your BPD journey, please consider Family Connections, which is offered by Sashbear, and you can find out more about that at our website. And if you are interested in any of the work that Amanda has spoken about today, you can contact her through her lab. Thank you again so very much. You clearly need to go and pay attention to your puppy, who's been very, very patient with us.
She's been very good, yes.
Great.
Thank you again. Bye, everybody.
All right. Good night, everybody. Thank you for joining us.